So I was on day 23. So they wanted to admit him. He declined and returned home. So on 24, that's the next day, continued vomiting and diarrhea, and then the difficulty in breathing set in. As you can see, we're now getting into the red. We had the black signs and symptoms highlighted. Now we're getting to the red. Now we're getting to the danger zones. Of course, as Ebola, when you start presenting with signs and symptoms, you start transmitting. So all this from 19th he has been transmitted, but because it presents like other diseases, we will not be able to catch it on time unless we are really, really vigilant, which we really encourage our health workers to be. So he begins vomiting, diarrhea with difficulty in breathing, and then the red eyes. Okay, we move on. On that same day, because now he was not breathing properly, the eyes are reddening, then he's vomiting, he has diarrhea. They take him to Saiden Abakar Hospital and is diagnosed with malaria this time and peptic ulcers. So they give him a test unit, and the father decides that since his son is sick, let me take my son to Mbale for further management. Reaching Mbale, probably they feel like the hospital is not doing enough. You know, when you are sick, you look for any kind of way to heal. Nobody wants to be sick. So they sought the help of a traditional healer in Mbale, but the diarrhea and the weakness persisted. Of course, as you're diarrheating and vomiting, your body is weakening. So a family doctor treated him for typhoid. So you can see all this. We have typhoid, we have malaria, we have maybe COVID, we have a pneumonia. All those are wrong diagnoses. So they took him to Mbale, Elgon Hospital. So we have a traditional healer now exposed. People he moved with in the car now exposed. So now he's at Mount Elgon Hospital where the X-ray was done for him and the blood tests. But he declined further care and he went back home. That is now 26. Those are like 7 days in between. So on 27th, they decided to transfer him back to Mulago Regional Referral Hospital. So he has moved from Kampala and then he has come to Mbale and then again he's gone back to Kampala. So now here the weakness and then the bleeding sets in. The bleeding of the gums, the red eyes, the severe respiratory distress also happens. And then is admitted at this point in time. So all this time has been declining care. Of course, it's typical of health workers. Feel like I can manage this, and more so the masculine gender. They feel like I can manage this, I can do this. So he's now admitted casualty in Mulago. So all this while he's been transmitting to people. And then on 28th, unfortunately, he showed signs of improvement. And then they transferred him to, no, actually on 27th was taken to Mbale Regional Referral Hospital and where he was managed. And then they transferred him on 28th when he showed some signs of improvement to Mulago. So we have about 4 facilities that have been contaminated by this patient's movement: the Alimu, the Saida Baka, the Mbale Regional Referral Hospital, and then the Mulago. So I bet some people are wondering, why is Mbalos an epicenter like the commissioner mentioned? It's because the patient also was managed in Mbale Regional Referral Hospital. So that is why it's also an epicenter. So they took him back to Mulago on 28th, and unfortunately, on 29th, he passed on after resuscitation efforts failed. And that is how our case moves. So you see that different signs and symptoms keep progressing as a disease also progresses. And this is how the Ebola that we have currently presents. So we should really be on the lookout for the different signs. Do not think maybe because I have difficulty in breathing, it may not be Ebola. It could be Ebola. So you don't take anything for granted. Next slide, please. So we have seen how the Ebola progresses, and this is currently the 8th Sudan Ebola virus outbreak in our country. So the map on our left is showing us the previous Ebola outbreaks that we've had, while the map on the right is showing us the current outbreak. So the outbreak was confirmed on 30th and declared. And our the districts in red are the very high-risk districts. So we have Kampala, we have Jinja, we have Iganga, we have Mbale. Jinja and Iganga included because the deceased relatives also resided there and currently they were also diagnosed with the EVD, so they also become high risk districts, and then very high risk districts. Then those surrounding them are the high risk districts because we have movement, like we saw. The population movements, we're moving every day. Like I mentioned, right now I could be in Kampala. In the next 4 hours, I'm in Bale. Before you know it, I'm in Tororo, and I've traversed our entire country. So the neighboring districts, people easily move in and out. Who work in Kampala but stay in Wakiso or stay in Entebbe. So those become our high risk districts. And the rest of the country is moderate risk. But again, we don't take any chances. That's why we shall do our targeted training in the very high risk districts and the high risk districts. But we have this that everybody is on alert. So that in case we have any case in a district, we're able to contain so that we do not have a long period of time of response. Next slide, please. Yes, so in all this, what is our role as laboratory in outbreak management? I'll first take you through this cycle that we have seen and how our response typically evolves. So we first begin with the physicians. So the physician is you're going to go and say, you're not feeling fine. So he's going to be thinking, what could the problem be with this patient of mine? So he's going to think hard and then maybe say it's a malaria. He's going to make a request. That is now we have the request after thinking so hard and looking at all the signs and symptoms. He's going to make a request. The sample is taken off. Of course, identification and all that. And then we have the sample transported to the testing lab. We also look at how our samples are transported currently to the testing labs. And then at the lab, it's going to be processed, analyzed, and the report is going to be given back to the clinician or the physician who requested for that test. So our responsibility lies in all this. In all this cycle, you have a role to play as a laboratorian, and you have a role to play to the patient and as a citizen. So we should always love our patients. We should always treat them with respect and so much love, because being sick is not nice. As we have seen, the patient had to really look for a way to get better. So we have a duty to our patients. We have a duty as a citizen of the country. So what do we do as laboratory during outbreaks? We have to develop preparedness and response plans. Much as we have a national plan or a district plan, laboratory, please participate in making of these plans. Sometimes we say they didn't put laboratory, they don't want to consider us, but you did not participate. So how will someone think about you or think for you when you're not there? So we should prepare, we should participate in the development of response plans so that we are able to get support for funding from the ministry, but also from the different partners that support the responses. And then we have to conduct a risk assessment and address the gaps. So we also need to know where is the issue, where is the risk. For example, in those hospitals, was the waste managed well? Were the people trained? Do you have knowledge? So we have to conduct continuous risk assessments as a country so that we are able to stay on top of our game. We have to be prepared at all times, and there's no better to be prepared other than having risk assessments. And then we have to always have a stockpile of required supplies and reagents to avoid running up and down. We have a case, we have a suspect, but we don't have PPE. So we should always be prepared and have PPE. We should always have PPE as laboratorians. I cannot emphasize enough on how you should wear PPE correctly, proper donning and doffing. Oftentimes you get infected in the doffing, but that will also be explained in the coming slides. Then we have to train. Colleagues, please do not go take over a sample unless you're trained. I am begging you, please do not go take over a sample unless you are trained. Much as they will tell you you're the lab manager, you're the hub coordinator, you're the what, please, if you're not trained, tell them, I am sorry, I cannot take off a sample, and we'll be able to get someone who is trained to take off that sample. That's why we have the rapid response teams at all levels. At the district, at the regional, and the national level, we have those teams. So they should be able to take off those samples. Do not send yourself, because you're going to be a statistic, we shall lose you, and then it will be very unfortunate for the country. And then as laboratorians, we have to do safe sample management.
When you go ahead.
So all those have to be taken into consideration. Safe sample management is our mandate as laboratory. It's not anybody's mandate. Triple packaging has to be strongly emphasized. Coordination of timely sample referral to testing laboratories. Colleagues, before you take off a sample, inform your hub coordinators. We're going to take off a sample, we need transportation. Do not take off a sample and then 2 days later, then you start calling. We have a sample here and it needs to be transported. Kindly inform the right people so that as transportation is organized for you and then the sample is picked in time and taken to the testing lab. We have results on time and then the patients are managed on time. So you can see that a delay on your side could cause a delay on the entire response and can cause adverse events happening, many morbidities, many mortalities, just because you kept a sample for maybe a day. So let us inform our hub coordinator, let us inform our national coordinator. All the people are there to help you ensure that a sample is transported on time. Then we need activation of the national reference testing and then the mobile laboratory. Currently, we have a mobile lab in Mbale and it's currently being set up thanks to the teams that are there. Thank you very much. So we usually activate the national reference testing. The one thing I should applaud our teams is they're always prepared. I am so proud of being part of the lab because our teams are always prepared. The Central Emergency Laboratory, the UVRI, they're always prepared. Now we have the mobile lab that is being set up. And the results management, these results have to be treated as confidentially as people's results. It's our role to make sure that the results reach the end user. So if a sample has been taken off, kindly make sure you get those results and then give them to the case management team to manage the patients. In the M&A report, you talked about evaluation. As laboratory, how have you performed? And this M&A should not be on only at national level. It should trickle down up the district level. As a district, how did you perform? As a region, how did you perform? Then you can also do at national level. Next slide, please. So in the preparatory phase of the outbreak, or as laboratory, what do we do in the preparatory phase? And also maybe our roles as laboratory. We usually define the cause and the magnitude of the outbreak. For example, if you have maybe 20 samples, you're able to tell the team that, look, it is Sudan Ebola virus. That is the cause. And what is the magnitude? We have 2 cases. So as lab, we play a very big role in the outbreak. We are able to tell the outbreak is progressing or the outbreak is going down. So the magnitude tells you how many people have been affected. And then we determine which samples are required. We should be able to guide teams on which samples to take. Colleagues, let's pay attention to the sample collection. Of course, the entire presentation, but sample types are really key because a wrong sample type is going to make it get rejected, or if this is going to take us a very long time. So let's take the right sample types, and then who will be in the investigation team for the laboratory. Like I can't, colleagues, be trained and competent before you participate in any outbreak. It doesn't matter how small it looks to you, but always have the training. That's why we are here today, and we're going to cascade the training to the different affected districts. And then you should always have necessary equipment, containers, transport media, packaging and transport. Please do not first go to the patient and start saying, oh my God, I do not have gloves. Assemble all your material that you need before you even reach where the patient is, before you even at the donning place. Make sure you have everything you need. Do not reach the patient and then you start saying, I forgot this. That is going to be very disastrous. And then contact the hub system for transportation. Please, we do not put samples on the bus. We do not put samples in private cars. We only use the hub system to transport these samples because that we are able to track where the sample is and if it has reached a testing laboratory. And then, of course, we shall identify the referral labs. Dr. Sanodi mentioned that the referral labs are currently using the UVRI, the Central Emergency Response Lab, and now the mobile laboratory. And of course, they'll determine the test to be performed, the sample requirements. They also give us guidance and then inform of the sample types and numbers referred and then expected delivery time depending on how long the assay will take. Please, as you can see, VHF sample collection must be by a trained personnel following an SOP in a designated isolation or holding unit or ETU only. Please don't be tempted to take off a sample when you're not trained and you're not following an SOP and you do not have the right PPE. Thank you very much. I think that's the end of my presentation. I would like to hand over to the next presenter. Thank you very
Yes,
much, moderator.
yes. Thank you, Winnie. And I just have a quick comment to make here is that we didn't anticipate this number, and the current link, I think, has a maximum of 500, and I know more than that number is already trying to get onto this. I've requested our technical team to reach out and see if we can have another link as we get into the other session. But one thing I want to emphasize from Winnie's presentation is us taking note of the virus structure and being cognizant that this is a filamentous virus, and also knowing that this has a glycoprotein that helps in attachment onto the host cell. That is very key. And this is an RNA single-stranded negative virus that we're dealing with, having a very high replication rate in the host cell. So these are some of the things that I would want us to always stick to and be very keen. Like you've seen how she has gone through the case that we had. In less than 10 days, we had lost this person. And I'm telling and insisting every lab person on this call and any health worker that this is how deadly RNA viruses are. They have a very high reciprocation. They replicate so fast, and they attach and create survival for themselves to have those virions produced, and that could be more infectious and spread the disease to others. So let's take keen eye on that, and also be keen on the high facilities or districts that have been mentioned. But don't think because your district hasn't been mentioned here that, okay, for me, I'm safe. We are having reports coming out from all over the country. The source of the virus hasn't yet been known, and it is nosocomial in nature as we are speaking right now, hospital acquired. It means we are not so sure about the community transmission. So those are some of the things that I want everyone on this call to be very keen and take note of. Don't say my district is not part of this, so I am not bothered. The other bit is knowing our roles as the lab. That is very key in what we are doing. Avoid being part of the dignified barrier team when you don't have that technical ability. These are some of the things we're trying to address. Know your roles as a lab. What do we do? Only if you have been trained, have the capacity to carry on these other skills elsewhere. Stick in your lane. And I would want to make this very clear again for us to take note that we always have steps we take when we are going to get involved in response. And I will stick to this and say for any Ebola and Marburg sample right now, it must be in a designated isolation unit or a treatment unit. And all these are under a control that there's a lot that has been made and has to be closed up by sample collection. So let's take note of this. The signs and symptoms, these are febrile patients, some of them, and we have these on a common basis, those who present with high temperatures above 38. So I want us to be very keen and take note of our lives as we are responding to this. So I just want to affirm her presentation as we welcome our next presenter. We are still seeing how best we can have the other link to ensure that we can make our colleagues also join in through. So at this point in time, Winnie, thank you so much for emphasizing. The last bit is that there is a new strain, the Bombali strain. At first, we were mentioning only 5 strains of the ortho Ebola virus. Now we have the 6th one. And this has been through guidance from the WHO laboratory diagnostic guideline that came out in 2024 in December last year. So we have to be also keen and updated with information so that you really know what we are dealing with. So at this point in time, allow Rogers Michael come in. I am requesting Doreen and anybody on this call to really provide us with that 1,000 capacity link if it is possible. So in case it is shared, we can switch to that link so that other colleagues don't miss out on these good presentations that are coming through. Rogers, you're most welcome. Rogers is a laboratory scientist with a well-versed experience in lab over 10 years. He has an infectious disease background, and he has been supporting policy guidelines and also ensuring that we build capacities for the laboratory in the country. So I want to invite Rogers to this call and let him have his presentation made. And let's be very keen because we're speaking about sample types, sample management, and how we handle these samples. Rogers, you're most welcome.
Thank you very much, Morgan, and thank you very much, Winnie, for that wonderful, elaborate curtain raiser and presentation made earlier. It is indeed, we can't emphasize further that this is a disease that will kill you, and it will kill you if you do not follow the guidelines. And yes, we signed up to follow the guidelines, and we are meant to follow those guidelines strictly to the dot. I would love to present to us the specimens of choice for testing for this Ebola virus disease. The biggest and the best specimen of choice for right now is the whole blood specimen in EDTA, at least 2 mils. So if you prick a finger and you start milking the finger and you get about 10 microliters, it will not be very helpful, colleagues. So if you are able to get capillary blood or venous blood, at least above 2 mils, so between 2 to 4 mils, we know when you're filling in that tube, you're supposed to get up to about 4 mils, and that is the one that the EDTA can be able to maintain. So the temperature for maintaining the specimen is between 2 to 8 degrees. And then the second option, and this option we want you to go to it only for death. You have a sudden death, they've presented a body before you, and none of us is trained, or you're not trained to collect sample from a dead body. Please, this is the second option you're going to use. You're going to take an oral swab, you're going to use an oropharyngeal swab, and you take an oral swab from the buccal cavity. Secondly, do not open the buccal cavity, as this is going to come through in my next presentation. This is supposed to be preserved in a virus transport medium at 2 to 8 degrees and then referred to the laboratory. But before you collect the specimen, what do you need to have? A completely filled in virus investigation form. And like we all know, the role of detection is for surveillance, and they should be able to help us complete this form up to section 4. They are going to be able to help us complete in that form. So the lab team comes in and completes section 5, not even up to section 5. Yeah, the lab team completes section 5 only, where we are talking of which type of sample we have picked, what time did we collect the sample. These are very important facts that we need to add. Please, dear lab colleagues, very important that you put the time you have collected the sample. Also very important that you put the date that you have collected the sample. I'm about to name the people who are drawing in our presentation. Oriema Geoffrey, please don't draw in the presentation. So then I can't emphasize much the need for having this form completely filled in.
Just kindly just go off and then reshare it again.
Okay.